Good afternoon. Welcome to this discussion on innovating women's health in Africa. It is a Roche Live Talk webinar, also brought to you live on CNBC Africa. I'm your host, Fifi Peters. When it comes to women's health, cervical cancer is the fourth most common form of cancer among women worldwide. And it's also the most common cancer among women living with HIV, who are 6 times as likely to develop cervical cancer. And yet, according to the World Health Organization, it is preventable and curable as long as it is detected early and managed effectively. Our panel discussion today will cover the innovations, critical issues, and the patient journey with regard to HPV cervical cancer, preeclampsia, and fertility within the Africa context, and the role of improved access in diagnostics in future-proofing African healthcare systems. But before we get to that discussion, we have a short talk to outline that context that will be brought to you by Sandra Orta, General Manager at Roche Diagnostics.
Hello, yes, my name is Sandra Orta. I'm the General Manager for Roche Diagnostics in South Africa and Sub-Saharan Africa. And welcome to our very first Roche Live Talk that we created to bring awareness on a specific health issues that we face in the continent, to really help us to empower people to really improve on and take informed decisions on health issues. This is Women's Month, and for that reason, we decided to take this theme and focus on women's health. We know that for the continent to completely improve health is central that we fulfill the health overall of the population. And we know as well that diagnostics plays a key role, and especially early diagnostics in that crucial role that health plays. At the same time, we see that millions of women in Africa face obstacles in every single step of their patient journey. According to the WHO, maternal health is a human right issue, and that covers pregnancy, childbirth, postpartum, and reproductive health. Unfortunately, we see that most of the maternal health happen in developing countries, 99% of the cases, and half of them happen in Sub-Saharan Africa. What can we do about it? That's the discussion that we want to have today. We know that the main issues of these challenges is severe bleeding at birth, infections at childbirth, and preeclampsia. Yet, all of these conditions can be prevented if they are diagnosed in time. We can talk as well about cervical cancer, one of the most preventable cancers that we have. Unfortunately, again, we have one of the highest burden of cervical cancer here in many countries in the continent. Due to poor access to prevention, poor screening, and lack of treatment in many cases, we contribute to 90% of those deaths. Today, we want to discuss this and much more with our panelists, because at Roche, we provide solutions in every single step of the patient journey beyond diagnostic tests and beyond medication, and we partner with health systems to really support improve healthcare in the continent. I'm really looking forward to the discussion, and thank you to your audience and to the panelists for all what we can do together to have an impact for our continent. Thank you.
And thank you so much, Sandra, for that beautiful and warm introduction. Before we get going with the discussion, let me show you the panelists that will be engaging with us. Professor Lynette Denny, the Chair and Professor of Gynecology at the University of Cape Town, Professor Ismail Borat, Associate Honorary Professor of Obstetrics and Gynecology and the University of KwaZulu-Natal's Zodwa Sitole, who is the Head of Advocacy at Cancer, as well as Dr. Nasia Sufi, the Medical and Scientific Affairs Lead at Roche Diagnostics Management Center for South Africa. Good afternoon to you all. I suppose my first comment would be, I think the fight against the COVID-19 pandemic has really eclipsed other ailments that we do face on the continent, especially if you look at the rise of non-communicable diseases in recent years and the fact that it is taking a lot more people in sub-Saharan Africa. So Prof. Borat, I'd like for you to kick off the discussion for us and perhaps just delve deep into some of the other health issues that we should be giving more prominence to, particularly as it does relate to women and issues around maternal health, sir.
Okay, at the outset, I want to thank Roche for inviting me to this important forum to share my thoughts on some important conditions affecting women's health. And I understand COVID has sucked up all the talking space for the last 18 months, as if that's the only condition facing us at the moment, but there are many other conditions that we need to focus on. And one of the important conditions that I want to talk about is preeclampsia. Preeclampsia is one of the most important obstetric conditions we face. And the simple reason is that it carries a huge healthcare burden on healthcare systems across the world. It doesn't matter whether it's a low-income country, high-income country, an LMIC, whatever the case may be. It's always up there as one of the three leading causes of maternal and perinatal morbidity and mortality worldwide. And the reason for that is that if you look at what is preeclampsia, pre-eclampsia is a multi-systemic disease that affects maternal organs or involvement. It involves the kidneys, it can involve the lungs, it can involve the brain, the liver, etc., etc. And that will equate to a very severe ill mom who often needs long-term ICU, both pre-delivery and post-delivery. And that's only one side of the equation. The other side of the equation is that many of these pre-eclamptic moms are going to deliver preterm because of the severity of the condition. And now one is dealing with a preterm infant and all the problems that you have to deal with that. Long-term stays in NICU, infection rates, ventilation. It's a devastating condition. So what is preeclampsia? So preeclampsia is the de novo development of high blood pressure. De novo means first onset high blood pressure after 20 weeks gestation, okay? And we link that with an endothelial involvement of one maternal organ. The common one is renal disease. So if the mother excretes excessive amounts of protein in the urine, we call that proteinuria. And the figure we look at is more than 300 milligrams per 24 hours. So if you have that combination of high blood pressure, first onset, after 20 weeks of pregnancy, with proteinuria, we make the diagnosis of preeclampsia. Recently, the meaning of preeclampsia has been expanded a little bit to say that if you have high blood pressure with other organ endothelial damage, not necessarily the renal, if it can be blood, can be lung, it can be brain, or whatever else, that even the fetus, if the fetus is growing small, so that's placental involvement, that you will say that patient has got preeclampsia. So what's the prevalence of preeclampsia? So preeclampsia, the prevalence is about 2 to 3% in high-income countries, and in low-income
Right, we seem to have lost.
It's as 10 to 15%. Hi.
We have you, sir. You can continue. You are just giving us the breakdown of the prevalence of preeclampsia in sub-Saharan Africa compared to the developed world.
Thank you. Thank you very much. So the prevalence of preeclampsia in high-income countries is about 2 to 3%, whereas in LMICs or low-income countries, it sits around 10 to 15%. Now, just think about that. 1 in 10 pregnancies is going to be afflicted with a serious condition of preeclampsia, okay? And there is this perception that the type of preeclampsia you get in low-income countries is slightly more aggressive and more severe than you get in high-income countries. One is not really sure whether it's a different disease process or the fact that there's inadequate healthcare facilities and therefore the mothers are not sort of consulting earlier, and it's giving space for a severe type of preeclampsia to evolve. So that question hasn't been fully answered. So the question is, what is the etiology of preeclampsia? In other words, what causes preeclampsia? Because for whatever else we're going to do, if we don't know what causes it, we can't fix it. So the central core problem of preeclampsia is placenta. It's placental maladaptation. Now, what is it that I mean? What I mean is that there are certain chores that the placenta has to do very early on in the pregnancy. Remember, the placenta implants between 8 weeks and 16 weeks. So there are certain chores that the placenta has to do so that it gets an uninterrupted blood supply of nutrients into itself so that it can function normally, because it's a very vascular organ. When it doesn't do that, when there's lack of placental vascular transformation, you get a concept called ischemia. In other words, the cells of the placenta begin to die off. And those dying cells then produce harmful substances, right? We call them anti-angiogenic substances, like esflin and endogamine, but you don't have to worry about that. Those harmful substances, they filter into the maternal circulation and they cause organ damage in the various organs that I spoke about. So you can see this is very, very serious, and it can also go into the fetal circulation. So when it enters into the maternal circulation, it can affect the kidneys. So you can have mild proteinuria, or the worst end of the spectrum you can get is renal failure. You can get the blood involved, where the blood doesn't clot. That means you can get mild clotting problems or severe clotting problems. We call that a DIC. You can get lung problems, where the fluid accumulates in the lung and the mother can't breathe. You can get a liver problem. You can get a brain problem, which is very, very serious. So in the brain, you get fluid accumulating around the brain. We call that cerebral edema. When you get cerebral edema, it can result in what is called eclampsia, where the mother is now going to fit. She'll have seizures. That's why we say pre-eclampsia, because it's pre the eclampsia. You don't want to get to the eclampsia stage, because once you get to the eclampsia stage, then the mortality is very, very high.
Right.
So if you don't treat pre-eclampsia and you don't do everything that you need to do to delay its onset, prevention, severity, and all of that, your end result is going to be eclampsia, where the mother is going to fit and seizures.
Which is what we don't want, right? Which is what we don't want, because the premise of this discussion is that a lot of the diseases that we'll be talking about are preventable if we are able to detect them at the right time. And so I will be coming to you in just a moment, but just to also highlight another ailment that women are more prone to, and particularly when you look at the numbers in high income countries compared to those in lower income countries and developing countries. Prof. Denny, perhaps if you come in here and just talk to us about the prevalence of HPV. What is it? How common is it here in Africa compared to elsewhere? And are we seeing the same level of inequality when you look at, the rates here in Africa or in developing countries compared to high income countries, ma'am?
Thank you very much, Fifi. So cervical cancer, or cancer of the mouth of the womb, is the commonest cancer amongst women in developing countries or middle income countries, in most countries. In other countries, it's second to breast cancer. Worldwide, it's the fourth commonest cancer amongst women. Now, cervical cancer is one of about 1/3 of cancers that are caused by a viral infection. And this is caused by the human papilloma virus, not to be confused with the HIV virus. So for short, we call it the human HPV. And this is a virus that has many, many iterations. There are about 200 different types of this virus, some of which, for example, cause the kind of warts that you get on your fingers as a child. Others infect the female or male genital tract. And if it does that, it can cause warts in women and in men. And in some women with specific types of HPV can be infected on the mouth of the womb. And this infection in over 80% of women will be cleared by their own immune system. But in a much smaller proportion of women, this infection is not cleared and it stays on the skin of the mouth of the womb, and over a 10 to 15 year period can lead to changes that can then develop into cancer of the mouth of the womb. So this is a very, very dangerous virus for some women. And in fact, if you look at the proportion of women in Africa infected by this virus, it's almost double that of women in high-income countries, related to many factors, particularly the immune system, and due to the high prevalence of HIV, which enables the HPV virus to multiply and to persist and to be more aggressive. And in terms of cervical cancer, more than 300,000 women per year die from this very serious disease, and over 85% of these women are found in low and middle income countries where there is the inability to detect the illness at an early stage. And there's also, in many of these countries, no access to proper treatment, because treated in the early stages, it's curable, this cancer, and there's no access to palliative care for the relief of suffering in these women. So it has a major and devastating impact on the lives of women living in low and middle income countries, causing the premature death of hundreds of thousands of women in a disease that can be prevented by simple tests, such as testing for cancer-associated HPV or even the pap smear.
And Prof. Danny, just very, very well. But I do have a follow-up question for you, ma'am. In how do you know that you potentially could have HPV? What are some of the symptoms that you need to look out for?
So in the majority of women who are infected, and men in fact, who are infected with the human papillomavirus, there are no symptoms. And the only way of detecting that is through molecular tests, some of which are in fact designed by Roche Diagnostics and other companies. So the virus is spread through skin-to-skin contact. And that's very important, because that means that anyone who has any form of sexual contact can in fact be infected with this virus. Mm-hmm, mm-hmm. So you cannot say, you're at lower risk, someone who's never ever been sexually active, or if they're two virgins having their first sexual encounter and there's been no exposure to human papillomavirus, their risk is low. But for the majority of human beings, you cannot really distinguish who is going to be infected and who is not.
All right. Okay. Point taken. Asymptomatic. I think that's a term that many of us have become familiar with in the past 18 months. And it is quite worrying, ma'am, that you do say that there are no symptoms in many instances. But Prof. Bharat, if I can also just briefly come back to you, if you could just also briefly talk to us about some of the symptoms and the early signs that people should be aware of when it does come to preeclampsia, sir.
Yeah, so I think one of the most important things, and some of the questions that we have to ask, is can we predict it? Can we prevent it? Can we treat it? Can we reduce its severity and delay its onset? And can we cure it? I mean, those are the important questions that we need to ask. Well, I'll answer the last question first. Can we cure it? Yes, you can cure it. But the only way to cure preeclampsia is delivery of the fetus and the placenta, which is not always feasible, okay? Because the mother might be very early on and the fetus is not yet viable. So we've got to deal with the problem. But can we predict it? We can certainly predict it for the reason that I gave earlier on. Because the pathophysiology starts early, between 8 and 16 weeks. And as I told you, that the diagnosis of preeclampsia is only made after 20 weeks. It gives us a window of opportunity to screen these patients. So if a mother comes early on at 12 weeks for a scan, we can actually do certain tests that can predict what her risk for preeclampsia is. For example, remember I told you there's not enough blood coming to the placenta? So we do a test called uterine artery Doppler. It looks at the blood flow velocity, okay, in the uterine arteries, all right? And if that resistance is very high in the uterine arteries, then the prediction of preeclampsia is going to be high. You're going to keep a very close eye on her. We can look at a biomarker, right? Like SFLT or PLGF, which is actually pioneered by Roche.
Okay.
There's a kit that you can use. If the PLGF is low and the SFLT is high, it means that you will be prone for preeclampsia. But the only way to detect preeclampsia, right, is after 20 weeks, is regular antenatal care. And there's three things we do. We look at blood pressure, we look at the urine, if there's protein in the urine, and we look at fetal growth assessment. Three basic things.
Right. So now in terms of that screening process, just drawing on linkages between what you have said and Professor Denny, that screening process, when you look at the stats between what is happening in high-income countries and lower-income countries, perhaps maybe another reason why we are winning in that race is that maybe that screening is not taking place as much as it should. And Zodwa, I'd like you to come in here, perhaps just to talk to us about some of the issues regarding the access to screening and why more screening tests aren't being taking place at stages of the game whereby some of these ailments, preeclampsia and HPV, can actually be detected. What are the barriers, Zodwa?
Thank you, Fifi, for that question. I'm really going to talk about the grassroots issues, you know, what women are facing at that level, at the grassroots level. First of all, messaging material are written in the language which the women at that level, they don't understand. I will highly recommend that then it needs to use the language of the local, language of the people are talking. It's such an important thing. But another challenge is that even if the women have been screened and with the positive results, there is a delay in referral, you know, system. It takes time for the woman to be referred. And thirdly, you find that you know, let me just make an example of South Africa. We do have a policy for cervical cancer, but the screening is very low. I think we really need to go aggressive in public awareness, using the people languages about screening. Why is it important? If I can just give you an example. You know, one woman said to me, Zod, I'd rather not know whether I do have cervical cancer or not, because I'm scared of that journey which I would travel. So those are the messages which we need really to tell the people that being diagnosed with cervical cancer is not the end of life. So once you have been diagnosed early enough, cancer, as Prof. Bobat and Prof. Denny has mentioned, that if it's detected early, it can be treated. So that's what I'm saying. So in a nutshell, I'm saying we really need to go aggressive with public awareness, using the local language And also what is important is to partner with other stakeholders, like the traditional leaders. Most of our people, they spend time going to the traditional health practitioners. If we work together with them, that will increase the early referral to the health facilities. We also need to work with the traditional leaders, Amakosi, because they've got so much influence within our communities. They can support us and just pass the messages to the communities that please go for screening. And the husband and brothers, they also need to encourage those women to go for screening. Thank you.
Yes, no, I wouldn't disagree with you. I mean, right now, if you look at the reasons as to why, for instance, the province of Limpopo is the most vaccinated province against COVID-19, some of the suggestions that have been put on the table, Zotwa, is the fact that, you had the whole community on board in delivering and spreading the message, including that of traditional leaders in highlighting the importance of vaccinating. But I'll come back to you as we just bring in Dr. Sufi here, because at the core of it, the core of issue of access to healthcare, I think that we all know that for some time access to efficient and affordable healthcare has been a challenge for the African continent. But perhaps let's just, talk more around solutions, ma'am, and just what you think at this stage is required to improve that level of access for more people to get credible healthcare services.
Thank you, Fifi, for the question. So it is a well-established fact that women all across the world live under incredibly oppressive conditions. However, particularly more so on the African continent. Now, in order for us, and this really affects all aspects of a woman's life, though more critically so is their access to healthcare. Now, in order for us to address the problem, the very first thing which needs to happen is that our governmental organizations, policy makers, the community needs to accept and be cognizant that men and women essentially differ, not only from a biological sex perspective, but also from a social gender perspective. And as such, their healthcare requirements, priorities, healthcare seeking behaviors will differ. And so on the African continent, we need to have healthcare systems that are truly responsive to women's healthcare needs. And from the Roche perspective, from our side, we on a daily basis strive to work proactively, collaboratively with every stakeholder across the healthcare sector to ensure that women are able to access healthcare in a sustainable fashion. Some of the programs, or to give you an example of some of the initiatives which we have led on the African continent, include the Global Access Program. Now, the GAP program was launched by Roche in 2014, and this was really to improve access to HIV viral load testing. Now, HIV infection rates were soaring at the time. So as Roche, we were incredibly responsive in ensuring this program was put in place to help the continent. Due to the resounding success of this program in 2014, moving forward to 2019, we have now extended the program to also improve access to diagnostics in the fields of tuberculosis, hepatitis B and C, as well as HPV, as Prof. Denny had pointed out, which are our next big priorities. And in doing this, we were able to create relationships with national health systems, governmental organizations, stakeholders across the ecosystem, which we continue to work with for future projects which we have in the pipeline.
And I suppose that I will agree that a lot more can still be done. Just going back to the statistics and the prevalence of some of these ailments that affect more women in developing countries as opposed to high-end countries. But just to bring it back to you, Professor Bharat, I mean, I don't know to what degree you can also just share your thoughts on HPV and the cervical cancer. So, and to which degree or to what degree, you know, when we're looking at testing systems, traditionally when you're going to your GP or your doctor and you're looking to prevent you know, any or check on any cervical cancer that you might have, maybe due to the fact that it has been you know, in your family, something like the pap smear is often you know, put forward. So, and I just want to know in terms of this particular test and the accessibility and affordability of this particular test, and what some of the guidelines from the World Health Organization in this regard are saying.
I'm a fetal maternal specialist rather than an oncologist, so maybe Lynette can actually answer that very fully. But from my own personal perspective, I mean, it's awareness. I mean, patients need to be aware that these conditions exist and that there is a stage of preemption. That's crucially to get that kind of message across, because a lot of people think that if you get cervical cancer, you're going to die, and they don't want to screen for it, they want to test for it. But there is this issue that everybody needs to understand, that's preemption, that there's a stage before you get cervical cancer. That is, if you have HPV and those subtypes that will predispose you to that, or you pick up cervical cancer very early, it is curative. So I think the issue is actually awareness. You've got to educate the population out there, and crucially, people need to have women need to get pap smears done. If they're sexually active, they need to get yearly or 2 yearly pap smears. So I think the combination of those things need to be put out there. Patients, the ladies need to be aware out there that these tests exist, that they are preemptive, that if they do find it, it doesn't mean there's a death sentence, that you can do testing and you can cure it. You can actually cure it. For example, if you have a CIN3 lesion, right, that doesn't mean you have the cancer. It just means that if you don't treat it, the risk of the cancer is going to be higher. So you can do a LETS procedure, you can do a laser procedure, etc., etc. But I think let's maybe pose the question to Lynette, because she'll give you more information, because it's an oncology-related question.
Sure, thank you. Thank you for that guidance. And Professor Denny, just your thoughts here. And, you know, when it comes to HPV screening and the traditional pap smear that most people are aware of, how the two systems differ and which one is more recommendable in your view?
You know, when the pap smear was introduced, it was in the 1950s of the last century. And where it was applied correctly, it reduced the incidence of cervical cancer on the interpersonal level to almost 90%, because it detects the lesion before it has formed into cancer. And if you can remove it at that point, you can prevent the development of cancer, or you can detect cancer at an early stage. But this required a laboratory and healthcare infrastructure that we've never been able to either initiate or sustain, particularly in sub-Saharan Africa. So this led about 25 to 30 years ago for many of us researchers to look for an alternative strategy to the pap smear for the prevention of cervical cancer. And my group was one of the first groups that introduced molecular testing for human papillomavirus. And it was a very nowhere near as sophisticated as these tests are today when we started 25 years ago. But what we found is that the human papillomavirus test was very, very accurate in picking up these pre-cancer lesions, more so, in fact, than the pap smear. Although it did tend to cause a certain degree of overtreatment. Anyway, over 25 years, we now have the ability to almost do what we call point of care testing, where a woman comes in, she can have a test and get a result of the type of HPV that she's infected with within.
Well, it seems we have lost Pref Denny there briefly. We'll get back to her to finish her thoughts once we have gotten her back up on the line. But Zodwa, I wanted to just speak with you a little bit more around the issue on, raising public awareness on some of these health challenges that do face women. And you mentioned the fact that awareness needs to be done more aggressively. So who leads that charge?
Fifi, before I answer your question, I don't know whether I got it. Before I forgot, I just want to mention, a week ago, I had an interview with one of the local radio stations, 10 to 15 minutes, talking about cervical cancer. So I work for Cancer Association of South Africa. We've got a free WhatsApp and a toll-free number. We have received more than 600 questions from the public, which shows that people are hungry for the knowledge. I was just talking Zulu to that radio station. So we are still dealing with those queries and the questions from the public. So I wanted just to stress that people are hungry for the knowledge, are hungry for that public awareness. Sorry, I missed your question, Fifi. What were you asking? Sorry.
You kind of answered it, because it was in response to how we aggressively get that knowledge out there to people, and you have highlighted the importance of speaking to people in a medium and in a language that they understand. But I'm saying to you, who leads the charge in being a lot more aggressive around raising the public awareness and even communicating, be it on radio or be it on leaflets, in languages that people understand depending on where they were? And I ask this intentionally because our government's finances are constrained. So who leads that charge in your opinion, ma'am?
That's not an easy one. I mean, that department should lead, but we need to support the government. We need to work together. We need partnership. The local community radio station, they need to come on board. The churches, they need to come on board. So I think we need to work in collaboration with other stakeholders, with the support of the government or us supporting the government.
I hear you. Dr. Sufi, maybe you can weigh in here. I mean, you spoke quite extensively about the few partnerships that Roche does have on the go to try and improve the access of health and health-related information to the public. Just on this area in which we have, or Zodwa has highlighted the responsiveness of the public to health issues when it's communicated in a language and in a manner that they understand. Just with your partnerships, perhaps, is there room, in your view, to perhaps also partner in this space of getting information out in languages that people can relate to?
Absolutely, Fifi, and I believe that was a phenomenal suggestion by Sodwa. Absolutely. So I am happy to relay that Roche has already partnered with various governmental and community organizations to accelerate disease awareness in the sector. And we are also exploring the possibility of disseminating this disease awareness or knowledge in a language and a format that is amenable to women who may not necessarily have a medical qualification, for example, to be able to filter that knowledge. So we are already on board in this regards.
Just staying with the issue of partnerships, and as I said, you did mention what you currently are involved with. But in your view, what else is needed to increase the level of health or access of women in the healthcare system in a more sustainable way?
Thank you, Fifi. So we are living under unique times where the expectations from our healthcare systems have never been greater. So from the Roche side, we are working collaboratively, as I had mentioned previously, with stakeholders across the healthcare ecosystem. But we are doing it in a manner such that we are responsive to the unique local requirements of women on the African continent. And our approach is also very specific and deliberate in that it is a patient-centric approach. And so what we are doing from the Roche side is that we are bringing a powerful combination of diagnostic technologies. And mind you, these are first world diagnostic technologies, which are now accessible to women in Africa, as well as treatment options. Now, this is the combination of diagnostic technologies and treatment options, which Prof. Borat had also alluded to in his response. Now, whilst we are bringing to the fore diagnostic technologies, treatment options, we also need to be aware that on the continent, we need to have systems in place that are able to utilize these technologies to their optimal potential and in a sustainable manner. And in order to do this, various stakeholders like our government organizations, our policymakers, our funders need to be open to engaging with the private sector. So we are able to work together to understand what are the possibilities in building these capabilities.
Ma'am, can I challenge you to be a bit more specific when you say that the governments on this continent need to be a lot more open to engaging the private sector? I mean, if you had a wish list now of asks in order to encourage further private sector participation, what would those pointers be?
So I would like to respond to your question, but I would also like for Sandra to come on board if she feels that she would like to add a few additional points. So very often, well, currently we do have good systems in place in terms of PPP partnerships, public-private sector partnerships, but these are still very much in their infancy. We need to be more open in our approach in that not every corporate organization is necessarily chasing a profit. Many organizations are sincerely committed to their corporate social responsibility mandate. And in that regards, there needs to be a more open approach to including us in these discussions and collaborating with us such that together we are able to pave a way forward for women on the African continent.
All right, point taken. Sandra, it's not in my brief to allow you to share your comments, but please do if you'd like to weigh in on what Dr. Sufi just said.
Maybe just to highlight that if we really want for our continent to have universal health care, having private-public partnerships is going to be critical. Otherwise, the challenge and the cost for the governments is going to be extremely high. And that's what we are eager to do, and where we are partnering already and testing on how we can do that partnerships, that we can really help each other for the continent. Because we all can build capabilities that can really support that change that we need for the universal healthcare that we all aim for.
All right. Prof. Borat, just coming back to you, so as we're discussing issues around fertility and infant mortality as it pertains to preeclampsia, just talk to us about the level of contribution that you are seeing here, and I suppose more specifically some of the common misconceptions out there regarding couples and the difficulties that they are facing regarding you conceiving a child.
Look, I mean, I think the rate of infertility seems to be increasing worldwide. Not sure what exact the reasons are, but in low-income countries, one of the biggest contributors to infertility is pelvic inflammatory disease. I mean, you have these young teenagers or, young women who have infection, and then because of the PID, which is pelvic inflammatory disease, the tubes become blocked. And that is one of the biggest reasons in low-income countries why infertility exists. So the awareness, again, that if you have a sexually transmitted disease or you have pelvic inflammatory disease, you need to treat it that early. You need to treat that early, because if you don't treat that early, it has long-term consequences. Again, it's an awareness and an education. If you don't know that an STD not treated early is going to lead to infertility, you may not want to treat it early. So I think that's the one issue. The other issue is infertility in low-income countries is regarded as a first world problem, if you understand what I mean. Medical aids, for example, and even healthcare facilities do not view infertility as a disease process as such. And I think that's a big, big, big problem, because infertility that afflicts a couple is as bad a disease process as anything else. It's irrespective of whether they are not physically sick or not. But from a psychological perspective, from a relationship perspective, from GBV perspective and things like that, I think it's a contributor. It causes tension in the families and all of that. And unless, low-income countries, and I do understand the priorities of low-income countries on other things, but infertility should be recognized, as far as I'm concerned, as a disease process. Like, you will not get in vitro fertilization in the public sector easily. Very few centers, I think, will ever offer it to you, but you'll have to go into the private sector. And I think this is also where the public-private sector interface needs to come in, that if the state cannot fund full IVF and full infertility, regimes, maybe they should partner with the private sector at lower costs. I think that stage or the time where the public sector and the private sector are antagonistic to each other is long gone. If we want to go forward, and if we want to progress, and we want to do everything that we are saying that we want to do, everybody has to come on board. The public sector, the private sector, the interface between them. That's the only way that I can see us going forward. Mm-hmm. Mm-hmm. I'm not sure whether other panelists agree with that.
I'm actually going to ask Zotto, because I agree with you that the time of, the two parties, being on different sides of the fence, as it were, is not getting us anywhere in terms of addressing our health ailments. And in South Africa, in fact, on the continent, it is this drive for universal health coverage. And Zotto, in South Africa, you would know that that is trying to be, or that government hopes to achieve that through the national healthcare insurance system. And I just wonder if this maybe is a solution to improving things like access to testing and screening and all things that can actually prevent a disease from actually taking a life. And if so, where are we in the conversation? As a stakeholder in the game, what can you tell us about where are those discussions on progressing forward with national healthcare coverage?
Thank you for asking, Fifi. I think those discussions are still in progress, and I will ask my colleague if they can add on this, but I know they are still in progress, and we had maybe the public comment where we have to comment on the NHI. So I'll ask my colleague to add on this, please.
And I'll come to the colleagues as well in just a moment. But Zotto, you also mentioned something very interesting in terms of improving the access to information about allowing perhaps the traditional healers, which many Africans do go to and do trust and do rely on, particularly those who stay in the rural areas, bringing in the traditional healers into the system. How do you think that will go down? How do you foresee a system like that actually working at a greater scale?
Fifi, thank you for asking that question. I was involved in a project for palliative care. We trained the traditional health practitioners on palliative care. The referral from the traditional health practitioners to the hospices, the numbers were increasing. It's just that building the relationship and respect each other. And we really saw the improvement. As Cancer Association, also, we are negotiating with the Department of Health if we can train the traditional health practitioners on the top 5 cancers and see how can we work together for them to refer the patients early enough, for cancer care. So it's just a matter of negotiation, and also the relationship building.
All right, ma'am. And Dr. Sufi, coming back to you, I mean, the point also of the discussion that we're having today is we're just here to highlight the role of diagnostics and the value of diagnostics in future-proofing our healthcare system, and particularly the challenges facing women on the continent. Just share your thoughts with us on that, ma'am.
Thank you, Fifi. So we know very well that unless we have access to diagnostic technologies that are timeless, effective, accurate, and sensitive, there is very little a healthcare provider can do to progress a patient and ensure optimal outcomes. So diagnostic technologies are really central to improved outcomes of a patient in the end. Now, for example, we have a wide portfolio of first world diagnostic technologies. One of them was mentioned earlier. Our HPV DNA test is able to detect certain serotypes of HPV that are very closely associated with cervical cancer. And as Prof. Denny had mentioned earlier, the quicker you are able to catch the warning signs of cervical cancer or predisposing factors in that regards, the better the patient outcome in the end. We have certain diagnostic technologies in place in regards to pre-eclampsia. Our AMH tests are able to detect ovarian reserve levels so that we are able to timelessly diagnose fertility. We know that 1 in 6 couples across the globe are affected by infertility. And as Prof. Borat mentioned, this is not only a physical dilemma, but also a heavy psychological burden for many couples as well. So we need to fully exploit these diagnostic technologies to ensure that patients are diagnosed as early as possible to ensure the best possible outcome. But that is not the only advantage. An additional advantage in having access to these first world technologies and having access to an appropriate diagnosis early enough in the treatment journey also means incredible savings from a budgetary perspective, where these funds can then be redirected to other healthcare priorities as well.
All right. Thanks, ma'am. We've got Professor Denny back. Professor Denny, I don't know if you want to just finish off the thoughts that you were sharing with us, just regarding the different types of testing for cervical cancer, the effectiveness of them, and also affordability. But also, if you can just add to that some of your closing thoughts, ma'am, on how we can improve access to healthcare in Africa.
Thank you very much, Fifi. I got dropped off the call, unfortunately. Yeah, the current WHO guideline, which is from almost 2 months ago, is that where feasible, that HPV DNA testing should be the primary screening test. And it is preferable over cytology because of its greater test accuracy. And so that is in the WHO guidelines, which are just about to be published. And I think there's a consensus around that. However, you need to have a menu of options, depending on the resources available in your particular area. So where there is a strong Pap smear program, that should be strengthened. Other programs use visual inspection of the cervix with acetic acid. Where that is working, that should continue. Where you're starting a new screening program, HPV DNA testing is the recommended test for the prevention of cervical cancer, including in low and middle income countries. The implementation of this, though, is going to be much more complex than I think many people realize. Because screening is not just about the test. Screening is about, and these are my most important take-home messages, is about coverage. You can screen 100% of 20 women and they will be protected. But actually what you want to do is screen almost 100% of the women in your population, even just once, will have a greater impact on the reduction of cervical cancer than screening, as happens in South Africa, where those with access to medical aid are screened almost yearly, whereas the majority of the population are not screened at all. And therefore, that's where the cervical cancer incidence resides. So number one, my biggest take-home message is coverage. My second is to create what Zodwa would call the grassroots advocacy. It's to create consumer demand. Women need to know that they can prevent cervical cancer. They need to know what cervical cancer is. They need to know if they go to their GP or their district clinic or their community clinic and they have abnormal symptoms related to bleeding and infection and so on, they demand that they get properly examined. They have the right to health and they have the right to demand to be examined. And thirdly, the only way we're going to succeed, even with excellent tests like HPV testing, is through strong healthcare systems. Mm-hmm. And that requires government, public-private partnerships, and it requires, at the end of the day, political will.
Mm-hmm. No, I agree with you 100%, and I think that you have summed up the conversation for us perfectly, Prof. Denny. I mean, the platforms like this, provided by a private sector player like Roche, are very important in highlighting some of the ailments that we should be giving attention to, and especially in this time when all the attention has been thrown at fighting the pandemic. Not to say that that is not important, but of course there are other things that also need to be given prominence. And Zodwa, I loved what you did communicate regarding getting the message across to people in the masses, but also making sure that it lands in a language in which they understand, because ultimately at the end of the day, then you're just talking to deaf ears and you are not solving the crisis at all. But the issue of coverage is very important, and it is an issue that I think will continue to keep players like yourselves at Roche and our government very busy as to how to ensure that we're able to bridge that gap of this weak public system that perhaps at best is inadequately capitalized with a more stronger, efficient private system that perhaps is not as affordable to the masses as possible. How do we bridge it? Is it more PPPs or private partnerships? Is it further incentives? I think these are conversations that we will continue to have. But I'd like to thank you all for participating in this discussion, and I'd like to thank the viewers for watching, and also those who are logged in on their laptops and gadgets. Thank you for your time. But that is my guests, Professor Lynette Denny, the Chair and Professor of Gynecology at the University of Cape Town, Professor Ismail Borat, Associate Honorary Professor of Obstetrics and Gynecology and the University of KwaZulu-Natal's Zodwa Sithole, who is the Head of Advocacy at Cancer, as well as Dr. Nasia Sufi, the Medical and Scientific Affairs Lead at Roche Diagnostics Management Center for South Africa, and Sandra Orta, the General Manager of Roche Diagnostics. Thank you so much for watching. Thank you for listening, and we'll see you again soon. Goodbye.